Well, good morning. Welcome to Sunday Morning Coffee with Dr. Childress here. So today I want to discuss resources I've made available to parents to provide to your various professionals, your legal professionals, your mental health professionals. Um, and and so let me get into it. I provided you with a lot of resources. Typically, I've said over the years that I work about 2 to 5 years ahead. Well, on some of this, I didn't anticipate COVID. COVID put a couple of years in there where things kind of froze up. So, but I published the booklets like back in 2016. I was thinking about that. So that's about 6 years ago, which puts it, yeah, about 4 years if you take out COVID. So, yeah, I work about two to 5 years ahead, which is an interesting thing because now at my age, when you start projecting out, 5 years, that's an iffy process. So we'll see what happens. What I did back then is I produced, well, first off, Foundations, the book. Now, Foundations isn't really a book in my mind. It's a tool, it's a resource. And what I did with this is I described the pathology using established knowledge. Family systems is the first level, then personality disorders, then attachment. And I link them all. So the attachment pathology creates the personality pathology, which creates the family systems pathology. So I describe it not only within each level, but across all levels, and I connect it all up. It's a very good book. It's a diagnostic treatise, is what it is. It describes what the pathology is in detail. Um, and so when people say, "Oh, peer review this," I can't put this into a 20-page journal article. So if you want to peer review the analysis of the pathology in the family courts, what it is using established, scientifically established knowledge, Foundations is what's going to do it. And so this is what you can just provide to every mental health professional and everybody and just say this. But look how big it is. So I created some resources that would be more available to you. The first one, well, I got three booklets. So these three booklets are the primary booklets to be handing out. Now, what these are is little pieces of educational information that you're putting in people's hands. And look how thin they are. So they're accessible to people. Um, and I purposely did that so that in the narcissistic parent, each one of these, triangulation of the child, is only a page or two, and it's based on quotes out of the literature. So I took all the quotes in the various categories, categorized them, put them into categories, and then provided the flow of connecting words that described the feature of the pathology, and then interwove the quotes into that. So this is a narcissistic parent. I wrote this one so that parents can provide this to your legal professionals. It says right here, guidebook for legal professionals. That's your GALs, your attorneys, and your judges. Now, I don't know how to get this in the hand of judges without biasing, but if you flow it into the legal system in your attorneys and people, it'll find its way over to the other legal professionals and the judges and stuff. And it's real simple, and it's based on quotes from the established literature, and it educates all your legal professionals. The other thing it does relative to me is it puts my name in front of the courts and the legal professionals and the mental health professionals and everybody you give this to puts my name in front of them. And that's a good thing for me, and that's a good thing for you because it puts all this information into their awareness. And they can Google me and get over to my website. There's a whole bunch of information on my website. We'll talk about that in a second. And so, there's a saying out of early childhood mental health that you have to give a toddler a new food 11 times before they'll take it, because the first 10 times you give them the new food, they go, oh, no, that's new, and I'm not going to eat that. The 11th time you give it to them, they go, I've seen that before. That's no longer new, and they'll try it. So basically, we just have to expose the legal professionals and mental health professionals to knowledge. And eventually they'll go, oh, maybe we should be applying this knowledge thing to the pathology we're working with. So that's what it gets it out there, and it gets my name out there, and it gets the movement moving um, on this. So this is one handout. This is probably your most basic booklet. Give it to your legal professionals, your attorneys, um, the GALs, parenting coordinators, but also to the mental health people. If you have a treatment therapist, provide them with this. But for the treatment people and the courts, I have a couple of additional booklets. The first is the assessment of attachment related pathology surrounding divorce. So it's not enough to just bang on people and say what they're doing bad. You also have to tell them what to do instead. Just don't leave people trying to figure things out on their own. You not only take them off the bad course, but put them on a proper course. So that's what I did. And I applied the knowledge that I have of attachment, family systems, and personality disorder, all the knowledge I have, I applied it and said, this is what I would recommend doing for an assessment. It's a six-session assessment protocol. You meet with the allied parent, the targeted parent, get their input. You meet with an older child if necessary, or you meet with a targeted parent and child. You actually observe the symptoms right there. You meet with the older child, hear their story, and then you put it in. Maybe do a little response to intervention as you um, meeting with the parent and child, and then you meet with the allied parent again, the targeted parent again. And in 6 sessions, you should be able to diagnose the pathology in the family. And so 6 sessions, we can do that in 4 to 6 weeks easy. I've done it in a day because it really doesn't require 6 sessions. I can do it in a couple hours. It's a mental status exam of thought and perception. The problem is nobody knows how to do that in the family courts. So, and the family courts want things formal and everything. So 6 sessions would be able to do it for most people, for most mental health people, and so that's 4 to 6 weeks. That's in competition with a forensic custody evaluation that takes 6 to 9 months and does not yield a diagnosis. This gets us a diagnosis. Is it child psychological abuse? Is there a shared persecutory delusion? And so this is going to focus more on the risk assessment side. And people say, well, I can't find anybody to do a risk assessment. You're absolutely right. Who's qualified to do, or who should be doing a risk assessment? Any mental health professional. That's their obligation. So it should be all of them. None of them are doing it. So holy cow, we have massive failure and duty to protect, massive incompetence, all of them. And nobody's doing anything about it. At the APA, the AFCC, nobody's doing anything about the massive incompetence, not the legislatures, nobody. Except maybe the New York Blue Ribbon Commission on Forensic Custody Evaluations. They looked into it and said, we need to stop these forensic evaluations because they're awful. And they are. So now I wrote this booklet for parents to be able to give to their mental health professional and to the court. So if your attorney, if they're saying, we want an assessment for this, and your judge says, what kind of assessment? You say, this kind, Your Honor, we want this. Now, good luck finding a mental health person to do it, but they can all get on, talk to me about it. If a mental health professional wants to do this, set up a consult. We'll sit down in my office and I'll go over this and we can talk about how to do the assessment. If they want to do it, they can do it. They just don't want to do it. Is a fundamental thing. And that's an important point to realize. The only problem is the mental health people aren't diagnosing child psychological abuse. Now, if you look at the child psychological abuse criteria, they're pretty vague. If they want to give a diagnosis of child psychological abuse for any reason, the mental health person, the licensed person, can do it. They're just not. Now, I give a criteria of a shared delusion factitious disorder as to stop the argument about it. So there's Dr. Childress's criteria: shared delusional disorder, factitious attachment pathology imposed on the child. Both of those would qualify clearly as child psychological abuse. A psychotic disorder and factitious disorder, Munchausen by proxy. Both of those are clearly child abuse. But cross-generational coalition, if the mental health person says that's child abuse, then that's child abuse. Here's the thing about diagnosis. Diagnosis is based on a pattern match of criteria to symptoms. But I've got a license, and that authorizes me to diagnose pathology. I'm authorized by the state of California to diagnose pathology in the state of California. And so if you symptoms meet the pattern of schizophrenia, hallucinations, delusions, conceptual disorganization, you've got a diagnosis of schizophrenia, whether you like it or not. And you can say, no, I don't have schizophrenia. Yes, you do. You meet the criteria. And if I give you a diagnosis of schizophrenia, Dr. Childress, you can qualify for services. You can get disability money. We can hospitalize you based on my diagnosis. So if that's the thing about doctors and license, it's very powerful, the power of diagnosis. We can pathologize people. You walk into my office, you don't have schizophrenia, you don't have ADHD. The child does not have ADHD when they come into my office. After my assessment, I give them a diagnosis. They now have ADHD that can qualify them for services and various things. So it's just simply a matter of diagnosis. And what forensic psychology did is they gave up their power. When they say, I'm not diagnosing pathology, I don't want to pathologize people. You don't want to identify what the problem is. When they do that, they give up their power to identify what the problem is. And then nobody knows what the problem is because the mental health people aren't telling them, and the judges now have to make decisions about what the problem is, what the pathology is. It's the mental health person's job to tell the judge what the pathology is. And my diagnosis is always accurate, by the way, because 100% of the time. I was trained at Children's Hospital. Misdiagnosis hurts people. If I don't know what the diagnosis is, I say, I don't know. Then I identify the information I would need to know to be able to diagnose it. Then I collect that information and make the diagnosis. That's what doctors do. And there's various ways. If I'm unclear even then on the diagnosis, response to intervention, there's various things we can do to get clarity on the diagnosis. But the mental health people, the forensic people, are just ignorant like a rock. So that's this, as you can get. And then in the first part of it, though, what I did was, before even describing the assessment protocol, I talk about the pathology, the healthy child development, attachment related pathology. And now so I do a little bit of a description about the pathology. Then in another booklet, the contingent visitation schedule, I also discuss the pathology, but from a slightly different angle. So if you have these both booklets, you're going to get a slightly different description of the pathology. One leans more family systems, one leans more delusional, psychotic. Now, the contingent visitation schedule is wonderful. Okay, the problem is here, you won't find the professional competence to be able to run it. A dialectic behavior therapist, because they know applied behavioral analysis, and it's pretty simple. It's just like a behavior program. So anybody who knows behavior therapy, any psychologist who knows behavior therapy will be able to do this easy peasy. Problem is, forensic psychology, they don't even know behavior therapy from the 1960s. Holy cow, applied behavioral analysis. Nope. Functional behavioral analysis. Nope. It's just insane how ignorant they are. But if you find, that's why I'm saying get the dialectic behavior therapist back, because they'll bring back um, bring in some established knowledge already, mindfulness training, some skills, distress management skills training, things like that, plus applied behavioral analysis. They know how to do that, which, and if you do that, you can tell authentic from inauthentic conflict. So we just need the knowledge over here. But this is really good because what it does, it looks like a behavior program, but it's actually a strategic family systems intervention. And what strategic family systems does, J. Haley, Chloe Madonis, is they look at families about how the symptom confers power within the family. Once you identify how the symptom's conferring power, in this case, it's giving power to the allied parent to manipulate the courts and to get their own needs met and to punish the other parent and stuff. So it's giving power to the allied parent. The symptom is, once you identify how the symptom is conferring power, you create a prescriptive intervention. You say, do this. And if the people do this, whatever it is you tell them to do, it's going to change the power dynamic in the family. And when you change the power, you're going to remove the symptom will no longer confer power. And the moment you do that, the symptom will drop away because it's lost its usefulness, it's lost its function of conferring power. Now, the tricky part of strategic family systems intervention is coming up with that intervention. And so that's why it's sort of a craft. What is the prescriptive intervention that if they just do it, they don't even have to understand why it's working. They just have to do what you tell them to do. If they do that, it's going to change the power dynamic and the symptom's going to fall away. And so it's that prescriptive intervention. That's what makes strategic family systems so hard. Most people stay with structural family systems. That's Salvador Minuchin. You see Minuchin's diagram and the structures and families. Strategic family systems, J. Haley, Chloe Madonis, very powerful. It takes a craft. It takes craft. Well, I've done that for you. So here's a prescriptive intervention. If you just do this, you'll solve the pathology, the continued visitation schedule. What it does is it says the court, let's say the court assigns 50-50 custody, which would be my general recommendation. All things being equal, things are equal, 50-50 custody. Now, every time the child, and then you have the outcome rating, the parent-child relationship rating scale. Everybody should be using this as an outcome rating. I'll talk about that in a few seconds. But the parent-child relationship rating scale. So now, if the child maintains, 3 or higher on this normal range, 3, 4, 5, 6, 7, but 3, 4, 5, just normal in the ratings, then that stays at 50-50. If, however, the child drops down to 1s and 2s and stays there, not just drops and bounce back, but stays at 1s and 2s on affection, cooperation, social involvement with the targeted parent, if they drop to 1s and 2s, that means those are the symptoms of psychological abuse. The child's being psychologically abused, again, by the parent. So that we reduce the time of the allied parent, the abusive parent, and provide more time over to the targeted parent in order to fix the 1s and 2s that are being created. The moment the child moves back into normal range again, then we reestablish contact with the abusive parent. So we make the custody schedule flex on the child's symptoms. As long as the child's normal range, then the custody schedule stays whatever the court decides. The moment the child becomes highly symptomatic, the time with the abusive parent drops, the time with the targeted parent goes up, and that changes the power dynamic. Before we intervene, every time the child becomes symptomatic, the allied parent, the pathological parent, gets more time with the child, and the targeted parent gets less time. We're reversing that. If the child becomes pathological and symptomatic, the targeted parent gets more time, and the allied parent gets less time. Well, that's no fun anymore. the symptoms no longer serving its function. So the pathological parent will stop producing the symptom because it's not serving their needs anymore. So that's the contingent visitation schedule. It's great. It'll avoid the protective separation period that's necessary. What it does require is the judge to authorize the mental health professional to adjust the custody schedule. Now, custody schedules are determined by the court. So the court sets the schedule 50-50 or every other weekend, whatever the court decides. But what the court authorizes is the treating family therapist to adjust that up or down based on specific criteria of the child's symptoms. So it's a child's symptom, and that's what's defined in this. That's why it looks like a behavior program. Every time this child's symptoms, and then there's some sort of consequence. And so the judge is not giving blanket permission to the mental health. The mental health person has rules to follow in terms of enacting this structured approach. And the rules are described clearly in this. And again, any mental health professional, you want to do this, you can get a consult with me and we can talk about it and how to do it. And as you're doing it, we can talk about it. Don't disclose confidential information. There's no release necessary. But it's going to take a period of time for the mental health people. 11 times, new food 11 times to a toddler, and we got a bunch of toddlers. So it's going to take some time. But if you give this to the mental health people and start passing it out, eventually, I think the AFCC would want to get something from Dr. Childress that would talk about the continued visitation schedule and these things. But I'm not applying to them. Okay, I'm not applying to present to the AFCC at this point. If the AFCC wants to talk with me, they can extend an invitation to me to come talk to them. But I'm not talking to them otherwise because they're child abusers. That's going to hurt the attorneys in the AFCC because you're not going to get access to what Dr. Childress could be telling you about how to move your case forward because I'm not talking to the mental health people because they're child abusers. Now, if you stop being child abusers and you actually want to solve things, send me an invitation. I'm more than happy to talk with you about stuff, but not if you're going to fight with me about it and continue to abuse children. I'm just going to come after your license is basically it. And then we can figure it out. If you want to put your license on the line and you think you're right and I'm wrong, and you put your license on the line saying I'm wrong, that's fine with me. Let's do it. I'll go through your report line by line, and you're wrong. You failed in your duty to protect. You failed in a lot of stuff. So those are the booklets, and I'm running out of time here. But the second feature is if you go over to my consulting website, you have a lot of resources over there. And so on the attorney resource section, that's the place where you can go and with your attorney get some handouts, and those are useful places for your attorney to kind of look at stuff. The resources that you have on that page are a description of the pathology handout. So I've given you descriptions in booklets and in books and a whole bunch of places I've described the pathology, but there's a handout right there, description of the pathology, where I describe the pathology. So you can say, here, patients should never, ever have to explain a pathology to a doctor. That just is insane. The doctor should be explaining it to the patient, not the patient to the doctor. Holy cow, that's such a low level of professional standards when the patients know more than the doctors do. Holy Toledo, but that's what you have in the family courts. It is it is below zero. Where are the licensing boards enforcing ethical standards of practice? They are nowhere to be seen. The licensing boards are nowhere to be seen. Why aren't the licensing boards having Dr. Childress run a training session on competence for your forensic psychology people? Because they don't care. The licensing boards are not protecting consumers from incompetent mental health people. The licensing boards are protecting the incompetent mental health people from the consumers. Holy cow, it's absolutely reversed. How did it get that way? Interesting discussion. So the description of the pathology handout. The other handout you're going to find useful on the attorney resource page is the risk assessment handout. That describes our responsibility as doctors, as mental health people, as licensed, to do a risk assessment whenever we encounter a dangerous pathology. There's three of them: suicide, homicide, abuse, child abuse, spousal abuse, elder abuse. Suicide, homicide, abuse. Whenever a mental health person encounters a dangerous pathology, we are obligated, duty to protect obligation, to either conduct a proper risk assessment or ensure that one gets conducted. For physical, sexual, and neglect abuse, that's a referral to CPS. For suicide, we do a suicide assessment where we get them over to an ER. And we have to know homicide assessment. Oh my goodness, duty to warn kind of things and tear us off. So we have obligations when we run into a dangerous pathology. Child psychological abuse is not a mandated report, and we legislatures should look at a little bit about including psychological child abuse and mandated reporting laws. But independent of that, each mental health person has a duty to protect. And because it's not a mandated report, that allows them to investigate. They're not allowed to investigate physical, sexual, and neglect abuse for multiple reasons. But they are allowed to investigate psychological child abuse because it's too sophisticated for CPS. And so, but that doesn't mean they can just ignore it and say there's no, they need to look. There should be a section in all court involved assessments that discusses possible child psychological abuse, and whether they found it or didn't find it or kind of found it, they should at least be discussing it. The only cause of severe attachment pathology, a child rejecting a parent, is child abuse by one parent or the other. That's the only thing that causes it. Less problematic parenting causes what's called an insecure attachment. Child's more strongly motivated to bond to the problem parent. Only thing that creates rejection is child abuse, potentially. And so we got child abuse. I know we have child abuse by one parent or the other. It's either the targeted parent who's creating the child's rejection. So let's take a look at that. And that's the argument of all the DV monkeys out there in Caden's law, is that the targeted parent is causing the child's rejection, two-person attribution of causality. Okay, so let's look at that. Because we need to diagnose child abuse 100% of the time. So that's a concern. The other possibility, though, is it's the allied parent, and it's a three-person triangle, the cross-generational coalition and the shared delusion. So it's either child psychological abuse by the allied parent or some sort of child abuse by the targeted parent, but we have child abuse one way or the other. If I've got a symptom of a child rejecting a parent, I have child abuse by one parent or the other. So if all your assessments are not resulting in a child protection response one way or the other, the child is being abused. I know that for a fact. Because there's child abuse, you're not protecting the child, you're not identifying which parent is abusing the child, accurately identifying it. So then you're not protecting the child. I know that for a fact. And so the whole system, mental health system, we really need to revise this. We need to get clinical psychology back with standards of practice, ethical standards of practice, professional standards of practice. Forensic psychology is a failed experiment in service delivery to a vulnerable population. So there's the booklets over the attorney resource section. The other potentially useful handout on the attorney resource section is one on my specialized expertise, because your attorney may find that valuable for how to qualify me and bring me in on the situation. So I have 6 domains of specialized expertise supported by my vita. So my expertise is not self-asserted. It's actually, no, you can look at my vita and you'll see where that expertise was acquired. So it's delusional thought disorders, 12 years at UCLA, schizophrenia project. Family systems therapy, that's what I do. I'm strategic family, so structural, Berzermani, Naji, it just family systems. That's what I do. Child abuse and trauma, clinical director. I've personally treated all 4 forms of child abuse. So our clinic major referral source was children in foster care. Attachment. I have early childhood, 0 to 5, mental health specialization. You can look. I know 2 different diagnostic systems for early childhood. DC 0 to 3 is stronger on attachment. DMIC is stronger on diagnosing autism spectrum. I'm early childhood specialization. I know 2 attachment pathologies for early childhood: Wait, Watch, and Wonder, and Circle of Security. And I'm trained in. I'm certified in infant mental health. I know the attachment system. That's where early childhood mental health is a specialization in the and a child rejecting a parent is attachment pathology. So I have experience in attachment specialization, specialization trauma, child abuse, in persecutory delusions, and in Munchausen by proxy, factitious disorder. I was trained at Children's Hospital. That's where we see that. So I have that. And then I have this court-involved pathology that I've been working for 10 years now. So I have a multiple domains of knowledge that no other mental health professional in the family courts. And standard 2.01 boundaries of competence says they should be consulting with me, because they're not competent and I am, but they don't. They just don't care about ethical standards. They don't care about competence. They don't care about solving anything. They just don't care. It's a motivational pathology. My favorite saying: don't try to teach a pig to sing. It just frustrates you and annoys the pig. So I'm not out here to teach forensic psychologists how to sing. It's their job to already know. Standard 2.03, maintaining competence. 2.01, boundaries of competence. 2.03, maintaining competence. 2.04, bases for scientific and professional judgments. Violations of all 3. Because they violate all 3 competence standards, their opinions is contained in their recommendations, reports, diagnostic or evaluative statements, including their forensic testimony, are not based on information and techniques sufficient to substantiate their findings. Violation of 9.01. 4 ethical violations, right off the top, for all forensic psychologists in the family courts. 4 ethical violations. Where are the licensing boards? Nowhere to be seen. So the other, if you move over on my consulting website, so I'll be wrapping up here, but move over to the consulting website to the mental health page, mental health consultation page. That's for parents to give to your therapist. You shouldn't be explaining pathology to a doctor. Doctors should be explaining pathology to a doctor. So you just shift them over. You'll have to know it, because they don't, and this is too important. It's your child, but that's their obligation to know stuff. It's not your obligation to teach them their job. So give them, link them up to the consulting page of my consulting website, the mental health page. On there, I have the instruments, and you can download these too, and you can fill them out too. Okay, you know what the symptoms are, so fill out the diagnostic checklist. Say, are these symptoms present? And then give it to your therapist and say, I'm finding these here. I'm finding attachment pathology. I'm a normal range parent. The child's rejecting me. The child is showing these narcissistic traits. The child is showing these phobic anxiety symptoms. And the child has a persecutory delusion. So I'm finding this. And holy cow, look at this. On the associated clinical signs, I'm identifying 7 associated clinical signs. So you can fill this out, give it to your therapist, and say, am I right? I'm not licensed. I'm just a parent. So can you tell me, are these symptoms present or not? Am I right? They don't. The idea that they don't tell parents what the symptoms are is just insane. The moment they tell you, though, it's child abuse. And I put the diagnosis right here on page 2 of this, because I lock them in. So if these symptoms are right here, I tell them the diagnosis right here is child psychological abuse confirmed pathogenic parenting. if you've got these three symptoms. So, are they present or absent? Get them to answer this. And the question becomes, are you a normal range parent? And everybody fights about that for years. And they continue to say you're normal as a parent, but then they don't carry that out. If you're a normal range parent, you cannot be producing the pathology that's being presented. Children don't reject normal range parents. That's impossible. All three of these symptoms are impossible. But that's where we use the parenting practices rating scale. Ask the involved mental health person to rate you. If you're level 1, that's clearly abusive. Level 2 is really problematic, but not quite abusive. So those are level 1 and 2 are abusive range. But level 3 is you got some problems, but you're normal. The parents are problematic, but maybe you yell sometimes, or maybe a little overwhelmed and get stressed out. But it's normal range parenting. That's level 3. You cannot be producing the severity of pathology if you're normal range problematic. That produces an insecure attachment. Or you're normal range healthy, level 4, which is most likely where most of the target parents are. It's level 4, normal range healthy, some more structured, some more permissive, but normal range. So get them to tell you and say, I want to fix my parenting. If this is because of me, tell me what I'm doing wrong. Specifically, so we can put it on a treatment plan and fix it. So tell me, parenting practices rating scale, please tell me exactly what am I doing wrong if I am doing anything wrong. And then tell me what symptoms are. Because Dr. Childress, who has all this expertise, is recommending to me as the parent that I get my mental health professional to complete these 2 scales. And you can look at his website and he will explain why he's recommending that you, as the mental health professional, do these 2 scales. The other handout that's available over, on this page, but also on my attorney page, is a telehealth consulting handout. That's going to also potentially be useful to you because it gives you a menu of all the possible ways to bring me in on a telehealth consultation. From actually sitting in the assessment through telehealth, I can be in any office anywhere on the planet. I can be watching any assessment. I can be watching any treatment session with the proper permissions. That's what telehealth allows. Holy cow, psychologists do this all the time. We do one-way mirrors. We do videotaping, recording. We do supervision, 2 years of supervision on our treatments just to get licensed, just to sit for the license exam. We have to go through 2 years of supervised therapy. We do supervision all the time. I had one-way mirrors at my clinic. And so getting telehealth consultation between doctors, easy peasy. And we should be doing that because second opinion is the appellate system for a disputed diagnosis. And so we know this diagnosis is going to be disputed because it's in the courts and one side or the other is going to dispute it. So rather than get a diagnosis, dispute it, get a second opinion, then dispute that, and now people are fine. Let's do it right up front. Let's get the second opinion right up front, put a second opinion watching the assessment, talking about the assessment, whatever. And so that telehealth starts up there and do that, or I can talk with them before, talk with them after. So